Tonight we have with us Dr. Fraser Henderson. I'm really glad that he's going to join us and do a brief presentation. And then uh, we will, after the presentation, we'll pause and we'll do a Q&A session. So with that, I'm going to have you introduce yourself and talk a little bit about why you got involved in Chiari research, and then go into your presentation.
Right, I'm Fraser Henderson. I'm on the executive committee for the Bobby Jones Chiari Syringomyelia Foundation, and I've been with the foundation the last about 13 years. Um, I'm presently adjunct professor at the University of Maryland, formerly I was at Georgetown University back in the late 90s, early 2000s. Uh, I My interest in this really began in my training when there was very little known about Chiari malformations. In fact, the morbidity associated with surgery for Chiari malformation was thought to be about 30%. I did a fellowship in craniocervical junction and spine and skull base in London, and ever since this has been my principal focus of interest and energies. So I'll give a brief talk here on the subject, and then that'll take about 25, 28, maybe 30 minutes. And then we could do 30 minutes of questions, if that sounds good. Right. I'd like to briefly honor my mentors at University of Virginia, John Jane, at Medical University of South Carolina, Fano Perot, and at the National Hospitals for Neurology and Neurosurgery at Queen Square in London, Dr. Alan Crockard, with whom I did my fellowship. And we saw patients with hereditary disorders from all over the UK and the world, in fact, um, mostly in those days with rheumatoid arthritis and lupus, and they presented with basilar invagination and craniocervical instability and terrible neurologic deficits. But in that study, Dr. Crockett asked me to look at 10 cadavers, patients who had died from basilar invagination, shown left. And he said, you will find ischemia. So get some pictures, we'll write that up and publish it. And much to his disappointment, I did not find evidence of ischemia, but I found these silver staining axon retraction balls. And at that time, that was back in 1993, I thought this is of major scientific interest, because what it shows is that the real injury is not from ischemia, but from mechanical deformation, stretching and deformation. We published that. I don't think many people were interested or believed it, but I teamed up with the chairman at Cleveland Clinic, a friend Ed Benzel, and others. And in the Journal of Neurosurgery, we published stretch-associated injury in the cervical spine. And over the course of the next decade, people came around to recognizing the importance of deformative stretch as a cause of neurologic deficit. And about 7 years ago, with a number of other department chairmen, we published this paper that I'm sure many of you have seen, the neurological and spinal manifestations of EDS, which are now becoming, I think, entering mainstream understanding. So this is the Chiari Syringomyelia Foundation. So I'm going to tie it in with Chiari as much as possible, but recognize that a lot of what I talk about exists separate from Chiari malformations. And in fact, the presence of the Chiari with this craniocervical instability does not appear to affect greatly its presentation or its outcome. But we know that simple Chiari decompressions fail. Some people say in up to 30% of cases. I think that's probably reasonable. And that may be because of ventral brainstem compression or brainstem deformity from a kyphotic clival-axial angle, or from the odontoid pushing back on the brainstem that's basilar invagination, or from the presence of atlantoaxial instability. And there's some authors say that 1/3 of Chiaris have some degree of atlantoaxial instability. I'm not sure I believe that, but and then craniovertebral instability is present in many of these cases. So I want to make clear that um, maybe craniocervical hypermobility is pretty common. But if you say instability, that means there must be neurological instability, uh, as demonstrated by a deficit and pain and imaging that is congruent with those symptoms. So, but if you have radiological findings of instability alone, that does not necessarily mean you have craniocervical instability. So the patient on the right is, you see a big Chiari and you see ventral compression, and it looks unstable, but that patient actually I've been following for many years, and her pain level is minimal. She's still working, and so I'd be hesitant to call that craniocervical instability until she develops real neurological symptoms. And keep in mind that if you have craniocervical instability, you probably have, in more than half of the cases, atlantoaxial instability at the same time. And in many cases, there's um, the C1 ring may be fused congenitally to the skull base. It's called a segmentation failure, or an assimilation, or a HOXD3. At any rate, C1 is really part of the skull, and that makes for a lot of instability between the C1 and C2. Now, most neurosurgeons are sort of familiar with post-traumatic craniocervical instability. So if you have high energy trauma and you come in, you've got a closed head injury and a spinal cord injury, then people are looking for a craniocervical injury. And so on the left there, you see separation between the skull base, the condyle, and the lateral mass of C1. So atlantocondylar spacing of more than 2.6 millimeters is highly suggestive of craniocervical instability. The next one, between the basion here and the top of the odontoid, if that space is, approaching 12 millimeters, that is craniocervical, radiological evidence, at least, of craniocervical instability. And here, there's a big gap between the anterior tubercle the atlas here and the dens. That atlantodental interval should be less than 2.5 millimeters. If it's more, then that implies rupture of this ligament, this one here, and instability at C1 too. Here's rupture of the tectorial membrane right here, and here, all signs of craniocervical instability. Now, there have been a lot of papers, of course, written about this, but it's important to remember that the CT findings with acute post-traumatic craniocervical instability are not reliable. They may be normal. That atlantoaxial instability frequently accompanies the CCI, and this is due to alar ligament incompetence, which is difficult to image. And the whole key in reading post-traumatic CCI is understanding the clinical picture. And that's really the same with Ehlers-Danlos syndrome when you get down to it. So 11 years ago at the Chiari conference, all these different programs, we achieved a consensus that ventral brainstem compression, kinking, deformation would be harmful to the upper cord and brainstem, and this would manifest as the cervical medullary syndrome, which is headaches, neck pain, and bulbar symptoms: altered vision, nystagmus, decreased hearing, dizziness, imbalanced vertigo, choking, dysarthria, dysphagia, dysautonomia, parts syncope, disordered sleep, and then symptoms of myelopathy: weakness, clumsiness, spasticity, sensory loss, urinary urgency and frequency. And we agreed that these three measurements would be helpful in defining these conditions. More recently, this was reaffirmed in the Journal of Neurosurgery by someone else, which is great because now it's established in the literature that that these three measurements are important. And in the same paper, they emphasize the importance of dynamic imaging, ideally upright bending, flexion and extension of the cervical spine. But if you can't do it upright, you can do it supine with a pillow under the head or a pillow under the chest, or flexion extension respectively, or a CT scan of the same way. Or you can even get a plain X-ray and see many of these things. So here's the clival-axial angle, normally greater than 150 degrees. Is the skull base, C2. If it's less than 135, you're in the potentially pathological. And I wrote a paper on this about 5 years ago, or six, whatever. And looking at all the literature surrounding the clival-axial angle, and then did a 10 patient cohort to exemplify the improvement seen with correcting the CXA, clival-axial angle. And about 13 years ago, we published this paper. We actually invented a finite element analysis program, which is a mathematical prediction of stresses and strains in the brainstem and spinal cord. And the stresses come out as colors. And we demonstrated very high stress in a lot of the pre-op patients shown on the left, and on the right, we showed how the stresses decreased after reduction, stabilization. And this correlated with improvement shown on the far right, improvement in pain and the brainstem disability symptoms. Now, the Grab-Oaks measurement is a measurement of potential ventral brainstem compression. So draw a line from the basion to the posterior C2, and the perpendicular measurement to the dura should be usually about 6 or 7 millimeters. If it's 9 millimeters or more, then that's reflective of possible ventral brainstem compression, and particularly in the presence of a Chiari malformation. So 9 millimeters is the threshold. Now, here's the measurement I really want to discuss, the Harris measurement. And there you see the basion to axis interval here, and that should be normally about 6, 7 millimeters. If it's 12 millimeters or more, then that is radiological evidence of instability. Same with the basion dental interval, the BDI should be less than 12. So on the left here, this is clearly abnormal, BAI of about 15 millimeters. And you can even see the spinal cord or the brainstem stretching. And so that's evidence of really bad instability. Now, there's a corollary to that if you take measure the BAI in flexion and say get 11 millimeters shown here, and then in B in extension, and you get 3 millimeters there, that means the skull has moved 11 minus 3 millimeters, which is 8 millimeters. And it shouldn't, in the normal person, shouldn't move more than 1 or 2 millimeters. In the EDS person, it shouldn't move more than about 3 millimeters. So I consider translation, as shown here, of more than 4 millimeters as being pathological. So if you look down here and there's pictures, there's a basion axis interval of about 11 millimeters on flexion, And then on extension, that's reduced to about 2 millimeters. So that's a pathological translation. So that's radiological evidence of craniocervical instability. And this has been um, also examined and endorsed by others recently in the literature. And also in the old literature, where they say that there should be no more than 1 millimeter of movement between flexion and extension. The skull, the cranium should be pivoting on the spine. It should not be sliding back and forward. Now, Atul Goel, the one of the top neurosurgeons in India, has done 1,000 craniocervical fusions, but he regards the joint between the skull and the C1 as being the most stable joint in the body. It's a ball socket joint. On the other hand, he regards C1-2 as the most unstable joint in the body. So how is it that we can have the most stable joint in the body becoming chronically unstable? And a new manuscript recently by Huang explains that, in fact, not all occipital C1 joints are stable. So this might be a stable ball and socket joint in a normal patient, and the skull rotates neatly there in flexion extension. But in Chiari malformations, there's some flattening of the superior surface of the C1 lateral mass, and it allows some sliding backward and forward of the occipital condyle. Condyle is the foot of the cranium. It's that round bone upon which the cranium sits on the spine. And so there's a little bit of movement with Chiari malformation. And if you add basal invagination, there's actually even more flattening of the lateral mass, the facet joint of C1, and loss of the posterior rim, allowing the skull to slide backward quite a bit on extension. So that's how we get craniocervical instability. You see this backward slide there. Now, I told you that probably the majority of cases of CCI are accompanied by atlantoaxial instability. And with Ehlers-Danlos syndrome, it's usually a rotatory type instability. With Down syndrome, it's usually an anteroposterior instability. But let's just talk about this rotatory instability. Here you can see C1 has rotated off the facet joint of C2, and it's almost ready to basically to dislocate. So shown in yellow there is the C1 ring, and it's slipping off the C2. We're just seeing a part of the C2 on this cut. And if that slipped a little bit more, it would be dislocated. And so with this kind of rotatory subluxation, we see, if you looked on a plain X-ray, the atlantodental interval looks quite normal. So most neurosurgeons would look at this and say, oh, well, that's normal C1-2. But in actual fact, the spinal canal is much diminished, and there's all this loss of facet overlap. And this is due to injury to the alar ligament, which runs from the odontoid to the medial condyle of the skull base. And these are very strong ligaments shown upper left there. But on the right, the alar ligament is actually being demolished somewhere. So that's that left. This is the left side. That's the right. That left ligament is gone. Now we can look for an incompetent or dysfunctioning alar ligament by putting the patient in the CT scanner supine and tilting their head one way and getting an axial CT, then tilting the other way, and getting another axial CT. And then we measure how much C1 rotates, and shown here, that's a rotation to the left because we're looking from the feet up to the head. And C1 rotated 85 degrees, and C2 here on the end rotated 40 degrees. So the difference is 45 degrees, and more than 41 degrees, you're kinking your vertebral arteries, and that's the threshold for subluxation. So we recently published a series of 53 patients with chronic craniocervical instability. And so we try to convey that, most patients, when they come to us, have been under treatment for years. But we want to have that have been maximized. And that treatment, what is non-operative treatment? It is avoidance of activities that bring on the pain, avoidance of any contact sports or things involving a lot of neck movement. It's strengthening exercises, isometrics. It's maintenance of good posture. It's maximizing your cardiovascular fitness. Good diet, avoidance of smoking, which can weaken the bones and ligaments, and then appropriate pain control and treatment of other conditions such as temporomandibular joint dysfunction, which can be very, very painful, and control of the mast cell activation syndrome and other comorbid conditions. So that's ideally all done before surgery. And understand that the surgery is not the first thing we do, it's the last thing we do. So generally, not always, but we like to see the headache 7 out of 10 or more, symptoms of the cervical medullary syndrome, which I discussed earlier, neurologic deficits, and the radiological findings. And in this paper, there were 50 females, 3 males, and because women present more with the instability. Before surgery, we look at the blood vessels on the MRI, and sometimes get CT angiograms to make sure that there's not some very abnormal blood vessel. For instance, this lady from Indiana had, every time she flexed her head, she'd go unconscious. And the MRI showed a low vertebral artery right here, and the vertebral artery was entering the dura 1 level low. So if we'd put a screw in right there, we may have inadvertently compressed or damaged that artery and caused either bleeding or a stroke that could have caused death. That was also the dominant artery. On the other side, the vertebral artery ended in a branch called the posterior inferior cerebellar artery. So it's good to know what these blood vessels are doing. Is another case where the artery there, the red arrow, ends in the posterior inferior cerebellar artery, a major branch, and the contralateral artery is the dominant one. But if that gets kinked with subluxation, then you can get brainstem symptoms or even a stroke. And this is the Kimberley anomaly, where bone overgrowth over the vertebral artery can pinch the artery and cause a stroke or dizziness or nothing, but it's important to know about it. The vertebral artery can be unusual in its location. Can be easy to injure, and an injury could be lethal. And the major branch, the pica, often has an unusual origination outside of the dura, but simply it's important to know the variations of where the vertebral artery can be, so you don't run into it. The anatomy for things like rheumatoid arthritis and Downs and EDS is makes the placement of a screw very difficult because the bone structures are very small. So those screws have to be placed with an accuracy less than 1 millimeter. And so we have a very good system of placing these screws. We do it, the same way every time. And it's been extremely effective in getting those screws in the right place, not getting any injury to the artery or other things. And the same with placing the C2 screws. You need to place the screw in such a way that it avoids that vertebral artery right there. And the C2 nerve can, if it's compressed or twisted, can cause horrible headache called occipital neuralgia. So when we do the exposure, we look for that nerve a little bit, and if we see it, then we take that nerve. Most of the time, however, the nerve is out of the way, and it's not going to be a problem, so we leave it there. After we put in the screws and everything's exposed, we release the head clamp from the stand, and I apply some traction, um, pulling it toward me a little bit, and then backward extension or a posterior translation, and then extend it a little bit to accomplish the reduction. So these are some of the things we look at: the clival-axial angle, the basion axis interval from the skull base to the top of the odontoid, the orbital axial angle, that's the gaze angle. It's where the person is looking in a neutral position. The distance from the spine to the mandible. If it's too much or too little, it can cause swallowing problems and speech problems. We want to make sure everything is straight, so no rotation or tilt. So we usually maneuver the Mayfield several times and take a fluoro, and then discuss the angles, and after about 10 or 15 minutes, achieve the optimal position of the cranium on the spine. Now, it's important when you fuse the spine, if you fuse the spine with the head tilted up too far, then the patient will have to flex the neck lower down. So that's a compensatory kyphosis below the level of the fusion. Alternatively, if you flex the head too much, let's say with a fusion at C1-2, then they have to extend their head lower down in order to have a level gaze, and that's a compensatory lordosis. So you want to avoid that. So how did our patients do? Of the 53, we had a very good fusion rate by using very thick, excellent quality bone, very big bones, and then we soak them for 40 minutes, and then we aspirate bone marrow from the iliac crest and inject it into that bone allograft, and what comes out is something that looks like a bone autograft, like the patient's own bone. And then, in addition to fusing with that bone, we get all the bone dust from all the drilling and mix some bone marrow with that, and we pack that into all the sides. So we have a very large amount of fusion material, um, probably about 5 or 6 times as much as you see in some publications, where sometimes they have a single little rib there, which is not enough. So this is the system, lower left, that I came up with a decade ago because I wasn't happy with the existing systems, which had pointy screws, and they're too big, and they weren't smooth, and there's no way to incorporate the bone graft. This one incorporates the bone graft into the device. And so this is an X-ray of what everything looks like. At the end, here's the bone graft, difficult to see. Here's a 3D image of it. So uh, headache pain frequency and severity, you can see decreased, but not completely. So, number one is these patients said the pain was very much improved, uh, and this is much improved, and so on down. When you get down to six, they said worsened, and so now these results were at 1 year. So some of these patients had worse pain, worse severity, but more than 90% of them had improved pain and severity and frequency. Uh, Now, these are the symptoms for which they were statistically improved. And if if a p-value of less than 0.05 is significant, so these values are all very highly significant. So they show that in almost all these patients that there's improvement in the photosensitivity, vertigo, dizziness, headache, neck pain, syncope, pre-syncope, that's where they almost faint, memory, concentration, double vision, photosensitivity, numbness, weakness, nausea, incoordination, speech difficulty, and fatigue, and also symptoms on the right of dysautonomia. So, but these symptoms are not gone at 1 year. They're just significantly improved, and they're still there. I think over the course of years, these symptoms will gradually regress, but they allow the patient to return to more normal living style. How about the Karnofsky Performance Scale? On the far left, 0 is dead, 100 is normal, like Caitlin say. The pre-op in blue, and you'll see a lot of these people were very disabled, and only a small number, very small number of them were actually working there with a Karnofsky of 80. And most of them were very disabled. After surgery, many moved into, many were then taking care of their children or going to college or working from home or returning to work. And this is at 1 year. When we did 5-year data, published that a few years ago, um, from a smaller set, we saw very good improvement in Kanofsky. And looking back, we asked, would you still choose to have this surgery given the opportunity? 75% strongly agreed, 7% agreed, 11% somewhat agree, and then a few here disagreed or yes, disagreed. And when asked why, the answer was they had so many comorbid conditions that the surgery didn't really help them because they were still immobilized by their dysautonomia and other and mast cell dysfunction, especially, and other problems. So the orthostatic grading scale at 1 year showed a significant improvement in frequency, severity uh, of those orthostatic symptoms, and the Wood mental fatigue test showed significant improvement in that. There's no difference between the Chiari subjects and the non-Chiari subjects. No difference between the patients with CSF flow obstruction and those without, which suggests to me that most of the symptoms arise from the instability and deformity rather than the CSF flow obstruction. But we did correct the CSF flow obstruction in everyone. Loss of motion does not appear to be a problem. I think it's exceedingly few people complain of loss of motion. Obviously, theoretically, you lose about 50%, but practically speaking, I fuse down to C2. I rarely go below, extremely rarely. I almost never go down to C3, which leaves open movement at C23, C34, C45, C56, C67, C7, T1, T1, T2, and sometimes between T2 and T3. So range of motion, not a problem. How about adjacent segment failure? In my earlier paper, 6 years ago, a lot of patients had more than half later underwent cervical fusions. And the so when we saw that, we've started recommending to the patients to avoid a lot of neck bending and to have better neck posture and be very careful about activities in which they could injure their neck. And since we've been doing that, the number of patients requiring fusions lower in the neck has gone down to about 30%. But those people who do have fusions down there had hypermobility or instability there to begin with. And so it's not like the instability began with the craniocervical fusion. It was already there. Moreover, in many patients, after the craniocervical fusion, the improved neuromuscular control of the neck not only makes the patients taller and stand up straighter, but it actually can improve the stability so that many patients who I thought would need a fusion at C45, C56, in fact, end up not needing it if the patients are disciplined about their posture and exercise. So how do these deficits and pain occur? Well, the headache and pain is mostly, I think, from the occipital nerve, which gets pinched between C1 and C2. That's occipital neuralgia, but also a lot of pain in the muscles and fascia and bones around the craniocervical junction. But how do the neurologic deficits occur? And I think the twisting of the brainstem at the C1-2 level with neck rotation causes stretching and deformation of those nerves. And in animals, for instance, we see injury to the sympathetic neurons. They're in green. And so stretching and deformity of those neurons could cause dysautonomia. And if you press on the brainstem, that causes stretching up and down, and that causes nerve injury. And the same nerve injury that I described in 1993 that no one believed, a year later, Pavlicek showed this with electron magnification, electron microscope, showing these axon retraction balls. And he was hailed as the brilliant scientist. And maybe one day they'll give him a Nobel Prize for showing this. Satman showed if you stretch a rat optic nerve 20% of its length, 3 days later you see these axon retraction balls. So this stretching and this excessive translation and rotation leads to stretching and deformity and injury of the neurons. Stretching neurons also alters the sodium and calcium channels and results in an influx of calcium going into that neuron, which is harmful to the neuron shown on the right. And it can also, stretching can upregulate the N-methyl-D aspartate receptors, which I think are responsible for some of the supersensitization of hearing and smelling and seeing, and makes the neurons more susceptible to injury and can trigger programmed cell death. But certainly with rotation, there's stretching, kinking of the vertebral arteries, and this can cause ischemia and headaches and dizziness and nausea. And in Choi's series of 21 patients with vertebral artery intermittent occlusion, they all presented with the same nausea, blurred vision, fainting, tinnitus, vertigo. these are all symptoms of vertebrobasilar syndrome. So if you have those symptoms in particular, that's a vertebrobasilar syndrome. And when you have those symptoms with fainting, actually, the fainting's right there. We often see that with C12 instability. So in conclusion, severe headache or neck pain, symptoms of the cervical medullary syndrome, especially weakness, lower cranial nerve dysfunction, like swallowing, speech, choking, and long track findings like hyperreflexia. These things should prompt consideration of craniocervical instability. The diagnosis is facilitated by upright flexion extension imaging. It's not mandatory, but it certainly helps. The horizontal Harris measurement, I think, is a very useful measurement for predicting instability. And appropriate fusion stabilization is associated with significant improvement of neurologic symptoms. But we have a long way to go to fully understanding what's going on. So let me open it up to questions now.
Thank you, Dr. Henderson. That was really great. I'm going to start with like the most basic of all basic questions, just because a lot of the people on this Zoom probably don't need this, but I know it's sorely needed elsewhere. So can you just explain what craniocervical instability actually is, and does it look different in patients without Ehlers-Danlos or hypermobility?
Okay, so it's simply pathological, abnormal movement between the cranium, the skull, and the spine that causes stretching and other irritating things that result in neurological symptoms and neurological findings. And it really looks the same in Ehlers-Danlos syndrome as trauma and other conditions, but frankly, I think uh, it's much more common with the connective tissue disorders. We don't see it very often in the non-EDS population, except with trauma.
I promise, guys, I'm going to try to get to everything. I do want to start with, is it unusual to not experience a lot of pain symptoms in Chiari and hypermobility, but to have more significant neurological symptoms like fatigue or dysautonomia? Is that usual?
Yeah. And men tend to present more with fatigue and less pain, and I think women probably have more pain, but uh, there are not nearly as many men presenting with CCI, and it's because male hormones stiffen and tighten the collagen more, and the muscles is stronger. And women go through, late adolescence, and that appears to be a ligament loosening evolution.
Interesting. That makes sense. And I know you touched on this, but this has come up in the chat and there were questions that came in ahead. So can you describe more specifically what tests and images really should be done to get that accurate diagnosis? Is upright MRI required? If not, what can be done instead? And then I'm going to add one more thing because there's interest in sleep disturbance. So are sleep studies also helpful?
Uh, the So a sleep study would be helpful. I published a paper in the 90s showing that uh, we identified 10 patients with basilar invagination who had sleep apnea when we did a transoral odontodectomy and removed the ventral brainstem compression. The sleep apnea resolved. So sleep apnea can be the result of brainstem compression, and getting that test might be helpful. The But actually, the earlier part of your question was what was the first part of your question?
It was just what tests should be done or what
Oh, the
imaging.
test, yeah. I think the upright flexion extension MRI is the most helpful for looking for craniocervical instability. But recognizing that AAI accompanies craniocervical instability in the majority of cases. It's helpful also to get either a DMX with the lateral, looking for lateral translation. I didn't show you that on this. Or, oh, thanks. Um, or um, or a CT scan with rotational views to look for C12 instability. They're the two main images that I like to look at.
Um, what I can't see. What would you recommend in a patient who's over 40? They've never been evaluated for CCI before. Are there issues with diagnosis if changes have already settled in, for example, degenerative disc, arthritis, stenosis? What's the best approach in evaluating someone who's
I
not quite?
think, yeah, I think the same tests. I mean, I think those measurements are valid no matter what the age, but they're always seen through the perspective of the symptoms and the degree of disability and the neurologic deficits. So it's the whole picture. But those two tests, I think, are valid for every age. I don't know about little children. Um, um, I think we don't understand their normal variation well enough. So I'm glad I don't have to make decisions with children under the age of say 15.
Um, Kind of sticking with diagnosis, this came in through the chat. What would you consider the primary or like top 5 clinical symptoms that maybe a physical therapist could be looking for as a red flag to refer for a surgery?
Yeah, number one, headache. And if you can include in that headache and neck pain. Okay. Number two, I would say visual symptoms, blurring, difficulty reading. These patients have a tendency of walking into doorways and people and furniture. It's not because they're clumsy, which is what they think. It's because they're seeing a tunnel vision. They're not seeing out here as well, and it's very common. The presence of syncope or nearly fainting is a real tip-off that they have instability. Weakness. When I see weakness, that makes me think of craniocervical instability. And on examination, hyperreflexia. You touch those patella tendons, and they kick out their feet. They're the biggest things. Um, you might many have Hoffman reflex. Many have um, some have a Wartenberg sign, which is if you uh, pull the hands like this, the thumb. Normally, the thumb will pull up like that. If the thumb adducts, that's a Wartenberg sign. I'm not sure how sensitive that one is, but there's often some dysdiadochokinesia. Next question.
So you did mention something about vision, and there is a question specific to that. So I don't know much about this, but can you discuss the prevalence of functional vision issues and what's the role of vision therapy maybe in recovery for craniocervical
Yeah,
instability?
I'm always a little bothered by the word functional because it often means fake,
Mhm.
that there's nothing really organically wrong. There's something functionally wrong. And it's a sort of a code word for maybe the patient's, hysterical and, whatnot. But it doesn't necessarily mean that. It just means that there's nothing, or it really means there's nothing organic. Uh, but I would say in almost every patient we see some convergence fatigue. Patients can read maybe for 5 minutes and then they tire out. they can't read for very long, and they have trouble remembering what they read. And I think it's because they they have because of the difficulty with convergence. They're not able to register the words and the symbols in the brain well enough to remember them. So the 20/20 vision, when you test them in the retina, everything it checks out normal, but they tire quickly, and so they need rehab for convergence fatigue, and they might need negative diopters on their glasses to improve, you know, but they often need the surgery first.
Mhm. And I know you touched on this a little bit in your session, but can you speak a little bit to the vertebral arteries and neurovascular issues and how these cases are specifically managed differently than other uh, patients with craniocervical instability?
Uh, well, the first, the vertebral arteries run up the side of the spine, and they provide blood to the upper part of the spinal cord and also the brainstem. So if you get ischemia from kinking or stretching or injury with a dissection, then you can get stroke-like symptoms or stroke. The worst case scenario, you could get a locked-in syndrome. That's extraordinarily rare. I mean, uh, I wouldn't be worrying about that. It's so rare. But so if you that last slide where I showed, vision, fainting, dizziness, nausea, the symptoms of the vertebrobasilar syndrome, that implies maybe a problem with the vertebral arteries, not necessarily, but probably. And so the treatment for that would be diagnosing it with a CT angiogram. Unfortunately, most CT angiograms are read as normal because if there is a blockage, they'll backfill. There's a lot of collateral flow. And unless there's something specific you're looking for, it's not going to alter the management terribly. Uh,
Okay.
okay.
I'm gonna try to get to there's so many questions. I'm trying. Can symptoms be transient? Can they come and go, particularly in the case of a patient with borderline imaging?
Yeah. Yes. I think the there are things like mast cell activation syndrome that can get triggered by the environment, stress, cold, heat, chemicals in the air, pollen, and these speak to the autonomic nervous system, and then that can cause postural orthostatic tachycardia and worsening of all of these symptoms. So it can happen from the ground up, from the mast cell, or you might have, that's altering your clinical picture, or you may have other comorbid conditions like TMJ, which can be exacerbating your headache, uh, or if depending on the hormonal balance that can affect the stability of the neck, so that there can be changes in the quality and severity of symptoms arising from unstable neck.
Um, Related to conservative pre-surgical management, how can someone reduce what they call a quote bobblehead feeling that can cause migraines? What would you recommend to relieve those everyday headaches or migraines prior to surgery?
Okay, well, first, good posture. Second, isometric exercises, pushing against a fixed object about 20 minutes a day. Third, good cardiovascular exercise. Fourth, diet. Fifth, very importantly, avoiding driving and all of those things that exacerbate the condition. Um, um, that'll
That
do for now. Yeah.
That'll do. Um, this is a good question. Can you just describe what the Grab Oaks measurement is? And in the absence of Chiari, what does it tell us about compression at the front of the brainstem?
Um, well, it's that measurement, the perpendicular measurement from the basion to the base of C2. If it's more than 9 millimeters, it's potentially pathological, and it may represent some pressure on the front of the brainstem. Strictly speaking, it's significant in the presence of a Chiari malformation. If there's no Chiari, then it's uncertain what the significance is. Uh, the we use it, but it was described in the presence of Chiari. The and it really predicts how much the odontoid is going to be deforming the ventral brainstem.
Um, this is a pre-surgical question, so it's a little long. Understanding surgery is a last resort. How would a patient with craniocervical instability really know that all those other conservative treatments have failed? So, how does someone distinguish between needing to strengthen muscles versus getting a surgical stabilization? And then, as a corollary, is there such a thing as getting surgery too soon or too late?
Well, the it's the probably a legion treatments from dry needling to naturopathic and cupping um, but the ones I've mentioned are the ones that I mean that's step one, and they're all things that the patient can do. You know, posture, diet, isometrics, avoidance of. Uh, but then for spasms, you can do injections. Some for migraines, you could do Botox injection. For TMJ problems, you can get a device, work with your oral surgeon to treat that. Uh, the uh, Centeno down in Florida can inject the ligaments with platelets and other things to stiffen them. So for very borderline cases, that can work. It if there's significant ligamentous instability, it's probably not going to work. But on those real borderline cases, it might. I've not seen published work, from his, group. Uh, the um, so as far as when you should have the surgery, uh, I will say that in patients where one family member had the surgery, then a year later a sibling suddenly came down with the same symptoms, and the family said, "Please operate quickly," because we don't want to go through years of suffering while we're waiting for surgery. And those patients uh, healed the quickest and went back to school or work, often within weeks. So the sooner you get it, the quicker the recovery time. That said, uh, we don't want to be operating on everyone when they think they suddenly need surgery. They should all go through, a full program of all those things I said, and many people won't need surgery. Um, so does that explain that?
And then before I get into some actually really great surgical technical questions that I really hope we have time for, if you don't mind, there's a question about advice on maybe sleeping positions. So there's a lot of sleep disordered breathing questions coming up. So are there specific sleeping positions that you find help increase stability and maybe reduce those sleep issues?
Well, sleeping with the neck brace on keeps the neck straight. It might not be very comfortable, but that probably helps. Uh, but I think in general, sleeping on your side with a neck brace and turning every couple of hours from one side to the other is probably a reasonable way to go. Uh, yeah.
Um, then this is a great question that I've never heard asked before. Does the severity of the either symptoms or the image, the measurements on the image, does the severity determine the risks of a surgery? So if there's a severe tethered cord, for example, would that increase the risks of the surgical um, treatment, or is it something else that manages risk?
Yeah, actually, on the contrary, the more severe the findings, the more likely the patient is to show significant improvement. So in that respect, it's less risky. You know, the real risk is that you never want is to operate on someone and then decide, well, it didn't help them. You know, that's the worst risk where that we hate the most. Uh, but there's certainly been. I've had many patients where I really wanted to run the other way, but but there were no university hospitals reaching out to them. On the contrary, most universities are now run by attorneys who push EDS patients in particular away, probably a lot of Chiari patients. They don't want them there. They want the routine fusions and things. Uh, the So no, I'd say the best results that I've seen were the worst patients with the worst symptoms beforehand.
Mhm. Um, so fusion's fairly permanent, obviously. What do you do in the operating room before or during the surgery to ensure that you're fusing properly with alignment? How do you?
We have Yeah, we have fluoroscopy, so we spend 5 minutes in the beginning, or sometimes more, making sure that the neck and the head and everything is straight. And then after we expose everything and put in the screws, then we reposition the cranium uh, to optimize all those angles and measurements that I mentioned earlier. And we have about 4 or 5 measurements that we use to make sure that we've achieved the optimal.
Um,
That's called reduction, meaning reduction of deformity.
mhm. And you spent the presentation and a lot of the Q&A session kind of talking about what makes a good candidate for fusion. But to put it the other way, are there specific things that would indicate someone's probably not a good candidate to get fusion, and um, or who would say maybe they wouldn't want to do it again? Maybe they disagree on those outcomes.
Does this include a political preference or only uh,
No, that is
uh,
apolitical.
the the yeah? I would say. I mean, I like to see real disability. For instance, if they're not disabled, uh, then they shouldn't be having this surgery. If they can continue their work and whatnot. Uh, but the say the absence of pain, disability, of neurologic deficits, uh, and um, minimal findings on a minimal radiological findings would probably predict a poor result. So the stronger the indications, probably I would say the better the outcome. And if we'd want to do a univariate analysis on all these patients and whatnot, but I think you'd come out showing just what I said. Is that
Mhm.
yeah?
This is more of a philosophical kind of question, but if we kind of accept that underlying connective tissue disorder is really causing the instability, and it's not necessarily being cured by the surgery because you can't cure uh, a connective tissue disorder with a surgery. There was a question about, is a fusion from C1 to C2 always sufficient to prevent that brainstem compression either now or in the future? Which, I mean,
Hmm.
I'm asking you to
I
see it.
mean, if the ligaments are incompetent,
Mhm.
then by doing the fusion, you obviate that incompetence. It's you eliminate that incompetent ligament with the fusion. So it is at the sacrifice of some mobility, but especially in the connective tissue disorders, mobility is not a problem. It's excessive, mobility. And so, I mean, philosophically, as you put it, this is exactly uh, the right thing to do to provide stability wherever the ligaments are incapable of providing it. Now, you're not going to do the shoulders and the hips and knees and all those things, but the craniocervical junction, the neck in particular, is if you don't have that right, nothing else in your life will go right.
That's true. Okay. If you will bear with me for the next couple of minutes, I have two more questions from prior that I just want to get to because I think they're great. Relevant to that. So, how do you know? I know you talked about this a little bit in your presentation about just doing the C1, C2, but do you ever go down lower, maybe in the future? Maybe there's reason to fuse lower. What are the specific symptoms that would make you consider like a bigger fusion in that sense, further down?
Well, some people go to lower. I mean, we always place screws in C1 and C2. If you can't or don't want to try putting screws in C1, which is quite difficult, then it's probably important to go an extra level. And so that's why I think some people go to C3. But I think it's unnecessary to go to C3 because the C2-3 joint is actually very, very stable. It's very seldom that we need to fuse that level. So I'd say 98% of the time we go to occiput to C2. Now, if they need a fusion at C3-4, C4-5, C5-6, then preferentially we'll come back and do that from the front so that we don't have to cut any muscle. Coming from the back of the neck, you have to strip away the muscle. And each time you do that, you lose about 35% of the muscle in the back of the neck. That causes weakness and sometimes, a little disfigurement. So I'd rather come from the front and you get a much stronger fusion and there's no injury to the muscle at all.
And then,
Uh, yeah,
okay.
I
uh,
think I think that answers your question, right?
yes.
Now, once in a while, there's really, really bad instability at every level, all the way down to C6 or C7, or even down to T1. So once in a while, we've fused all the way from the skull down to T1 or T2. So occasionally it is necessary, but that's a rare phenomenon.
And then kind of speaking to those post-surgical long-term outlooks. So if things are going well post-operatively, do you recommend follow-up scans of any kind? What would those be? And are they at regular intervals? And I know you kind of talked about your study where you went out to 5 years, but I mean, 10, 20 years out, is this something that we want to keep following? What do patients do after surgery to ensure
Yeah,
that?
actually, yeah, we're gonna do a 5-year follow-up on those 53 patients here, but it would be really great to do a 10-year, 20-year follow-up. That would be outstanding. It'd have great economic significance too, because I would say 95% of the patients we operate on would be disabled for the rest of their lives without surgery. But most of them get back to it's a very exceptionally bright group of people, and they get back and they make major contributions.
Mhm.
So we need to do the 10 and 20-year follow-up. Yeah, that's a good job for you, Caitlin.
Yeah, we'll do our best to help you with that. But what should patients do post-surgically to kind of maximize that functionality after surgery? I guess this is kind of the question.
Okay. I understand that if they were 10 years getting to where they were, it's going to take, at least 5 years to get back to the way they want to be.
Mhm.
The longer they were disabled, the longer the recovery period. So, uh, the skin may heal, the bones may fuse, but that's only the part of it. The nerves have to heal, and then the neurological behavior has to change. You know, the you know the how the body responds in the environment, and the shape of the bones and the strength of the ligaments, and these processes take years. So the person has to be patient and play it quiet and slow and steady, and begin exercising their brain, exercising their body, having really good health habits, posture, diet, no drugs and alcohol, smoking, regular exercise, regular sleep, avoidance of activities that are potentially injurious. So paying attention to studies for 4 or 5 years, getting another graduate degree is an excellent thing. And then, but I think for many people, it's a 5-year process before they fully blossom.
That's a fair point. And I'm thanking everyone, especially Dr. Henderson, for staying on. I was a terrible moderator. We're at 8:40. So I'm going to wrap this up today, and we're going to request that Dr. Henderson come back because there are so many questions that we did not get to. But Dr. Henderson, if anyone wanted to find you, how would they do that to come see you or ask questions?
Well, our the Metropolitan Neurosurgery Group website. It's seldom that I look at it. I suppose that has an avenue. You can send me an email, although I get a lot of emails. I'm not always good about that. If you have an urgent thing, you can text me. If you have an urgent problem with a patient, um, and my telephone number is 202-297-8858. People have been very good at not calling me unnecessarily, so that's why I'm willing to give it out. But there are a lot of people I see here who really do great service to many of their patients. So I want to thank all of them for the really excellent work they do. And so um, yeah, yeah. So
Yeah,
let me know. Yeah. Okay. All right. Good.
without their help, no one would get better. So I agree.
That's right.
You for joining. Dr. Henderson, thank you so much for this. We're definitely going to have to do this again. I apologize in advance because there were about 100 questions that we got, not counting the ones that came in through the chat, and I had to consolidate a lot of them. So thank you everyone for being
Great.
patient.
Hey, great job, Caitlin, as always. All right. Nice to see you all. Take care.
Good night. Thanks everyone.
Bye now.